in modern radiology right now. We don't want um, like the same differential diagnosis for every case. We need a short and logical differential diagnosis. And in your practice as an orthopedic surgeon, you need to determine whether this lesion can be left alone or something that needs an additional workup or a referral to a tertiary care center. So it's very difficult really to accurately assess all these cases because not so many of these cases are reported. Like fair frequently you see cases in your clinic, but you don't report them. So the incidence of all these incidental lesions is very difficult to assess, but I can tell you they're very common. And quite often you see cases in your clinic. I'm sure if anybody of you did rotation in arthroplasty or upper extremity, you saw so many lesions that turned out to be benign lesions like inchondroma, non-ossifying fibroma, and stuff like this. And there are other lesions that are discovered incidentally on imaging. When you do an X-rays for a patient who had a rotator cuff disease, you find a lesion in the proximal humerus. And if you know how to describe this lesion, then you will be able to reassure your patient and tell him this is an inchondroma, this is something benign. We don't want to do any further imaging, just we need to observe it. So you stop at this point and you don't need histological diagnosis or further imaging like MRI or stuff like this. But there are more data on malignant tumors since they are more likely to be evaluated. While benign tumors, we don't usually go beyond the clinical and plain X-rays evaluation. That's why we have no accurate statistics. But primary bone tumors are currently very rare. And by far, the most common bone tumors are metastases. Out of 100 cases of bone tumors, 95% of them are metastatic, while primary bone tumors are only 5%. And you know, primary bone sarcomas, they constitute about 0.2% of all neoplasm. So out of 1,000 neoplasm or cancer, we get 2 primary bone tumors. And the incidence of soft tissue tumors or sarcomas is 10 times much more common than the incidence of primary bone cancers. So like I can tell you the commonest tumor all over is plasma cell myeloma or myeloma. And there are other primary bone tumors like osteosarcoma, chondrosarcoma, primary bone lymphoma, and other tumors. While benign tumors are much more common, and these are common tumors that you can see in your clinic. Osteochondroma is a very common disease in pediatric age population, or even in the second decade of life. And if you see a patient, the patient comes to you like complaining of knee pain, you did an X-rays, you find an osteochondroma. At this point, if the osteochondroma shows you a benign features, you need to stop at this point. There is no need to do further imaging unless if there are some changes that tells you this lesion could be worrisome of malignant degeneration. As you all know, inchondroma is extremely common. People who worked on shoulder surgery or upper extremity surgery, it's very common to see inchondromas in the proximal humerus. And these lesions are like incidental findings. And if you know the features of inchondroma, which is benign latent disease, and we will talk about benign latent disease, these you can stop at this point and no need to do further imaging. And giant cell tumor also can be discovered incidentally, especially if it's small. Osteoid osteoma is a very classical features of benign active disease. Fibrous dysplasia also is in 5% of the cases, and the benign active disease. Again, we will concentrate and we will stress more. What do we mean by benign latent? What is benign active and what is benign aggressive? But all in all, you need to look at the clinical and radiological and pathological classification. Like the false impression that the pathology is always the final decision about what kind of bone tumor is. This is not right, because even the pathologist, even if you take a biopsy from a tumor, he will tell you, please correlate with the clinical and radiological findings. So the triad of a clinical, radiological, and pathological evaluation, this is extremely important to provide the best diagnosis or the final diagnosis for you. I can tell you just a classical case scenario. If you have a patient who had sustained a trauma and he sustained a stress fracture, and if you don't know how to read the x-rays, if you did not take a proper history and you ended up taking a biopsy of that lesion, the lesion will show on the pathology as an osteosarcoma because stress fractures, when they develop callus, the pathologist will read them as the callus as osteoid formation. Without proper clinical history and without proper clinical evaluation of the radiographs, you will be deceived with the diagnosis of osteosarcoma. And I have still remember a patient, a young female patient, where she had a stress fracture of the midshaft of her femur, where her treating surgeon took a biopsy out from there, and the pathologist diagnosed the case as osteosarcoma, and she eventually underwent above the amputation. But when we looked back at her x-rays and her clinical evaluation, this patient sustained a trauma. She fell down, she had a fracture, and looking deeply on the pathology, there was an osteoid formation, but that's not a malignant osteoid. So again, team evaluation is extremely important. What do you mean by clinical evaluation or evaluation? We take a thorough history, complete physical examination. And when we talk about physical examination in bone tumors or bone lesions, we have to examine the patient completely from head to toe. Because again, like you see a patient who's a 40 years male patient or 50 years female, she comes to you with an abnormal lesion in her x-rays. Remember, the commonest tumors in patients above age of 40 is METs, myeloma, lymphoma. So you need to look for evidence of any primary carcinoma in her body. So you do complete examination from head to toe, including the lymph nodes in the axillary, in the cervical, including a thyroid exam, breast exam, abdominal exam, lower limb, lymph nodes, all joints, everywhere. And then you finally go to the plane radiographs in two orthogonal planes, again, the entire extremity, and you put your differential diagnosis. You go for further investigations if needed, like a PET scan or bone scan or a CT or MRI. And based on this clinical evaluation, you decide your management. So pain is extremely important. The commonest presentation of any bone cancer or bone sarcoma is pain, while the commonest presentation of soft tissue sarcoma is swelling. Pathological fracture is one of the presentations also of bone cancers. We have seen so many cases of pathological fractures in patients with primary bone sarcomas or secondary metastatic disease to the bone. Sometimes you see these patients as incidental findings. And I can tell you, out of our practice, probably 40 to 60% of these patients, they come as an incidental findings. And always these patients report a history of trauma. So any patient in general, any patient who sustained a trauma, especially in the first and second decade of life, any patient who sustained a trauma should get an X-ray. If the patient pain is not justified by the magnitude of the trauma, or there is no justification in X-rays, 4 weeks later, you have to go for a cross-sectional imaging, including MRI. And this is one of the strict guidelines and criteria of the American College of Radiologists, where patients have to undergo imaging if their pain is not justified by the magnitude of the trauma and you do not find any X-ray findings. Because again, for somebody who's not experienced in oncology, we always like you to really dig deep in the x-rays, zoom in, zoom out. If you cannot find anything, patients still complaining, there is no harm of going for MRI. Age also is extremely important. Again, before age of 40, it's totally different differential diagnosis, while METs, myeloma, lymphoma is much more common above age of 40. Gender is extremely important. There are conditions that occur more predominantly in females and others that occur predominantly also in males. Constitutional symptoms, they're very rare in primary bone cancers. And by the time your patient gets a constitutional symptoms, definitely this patient is currently metastatic or he had Ewing sarcoma, because Ewing sarcoma comes also with constitutional symptoms, or in patients above age of 40, this patient is metastatic. Also, you need to take a thorough family history. You know, there are so many syndromes that are associated with family history of predisposition to cancers, like Lou-Ferrigno syndrome. We have seen so many cases or so many families here in the Eastern Province with a history of Lou-Ferrigno syndrome, where patients are in a high, like they're susceptible more for a high incidence of soft tissue sarcomas, bone sarcomas, breast cancer, and other solid malignancies. And you need to take a full history about any breast complaints, GI complaint, thyroid, urinary complaints to rule out any metastatic bone disease. Again, this paragraph is extremely important, and it tells you that there are certain tumors that occur in certain age group. And if you concentrate more, most primary bone tumors, they occur in the first and second decade of life, like osteosarcoma and Ewing sarcoma are common in pre-pubertal or close to pubertal age, while METs, myeloma, lymphoma, they typically occur in patients above 40. Now, that does not also tell you that do not think about metastasis in patients less than 40, because these are all Western statistics, and where all these patients below age of 40, they're screened for metastatic, for primary cancers like breast cancer. Females, they have a regular self-examination. They're trained to do regular self-examination. They go to the primary care, and males, they undergo yearly investigations. So it's extremely unlikely in the Western population to get a patient who had a metastatic breast cancer below the age of 40, because they typically pick them up before they get metastasis. While in our population, in our culture, you still have to think about metastatic bone disease in even less than 40 years of age. And we have so many examples where patients come to us with pathological fracture, abnormal bone lesion. And guess what? She's a female, 25 years female patient, and she came with a breast mass, undiagnosed, fungating breast mass. She's very shy to go to the doctor, and eventually it's a metastatic. So just be cautious about metastasis about in these age group. Well, as we know, myeloma and lymphoma typically occur in above age of 40. Now, lymphoma, the systemic lymphoma is above age of 40, but there are cases of primary bone lymphoma that occur less in younger age groups, especially the second decade of life. Like, look at this X-ray. The one on the left side is a 60 years. He's a patient of mine. Is a 60 years male patient. If you look, as I said before, above age of 40, you think of Mets myeloma lymphoma, and this patient had a renal cell tumor in the proximal and with pathological fracture in the subtrochanteric area. While this patient on the right side, she's a female patient. She's actually the daughter of one of our MSK radiologists. He works with us in the sarcoma team. And this is his daughter's X-ray. If you look carefully at the X-rays, you will know later that this is a very aggressive looking bone lesion involving the entire humerus, and it was Ewing sarcoma. So looking at age, you will be able to go which direction of differential diagnosis. Again, this is from, again, the same website, radiologyassistant.nl. This is in less than 30, you think about all bone tumors, osteochondroma, ABC, chondroma, solitary Ewing sarcoma, while above age of 30 or 40 is Mets myeloma lymphoma is common. But here you also have to know that giant cell tumor is one of the tumors that occur after skeletal maturity. So before skeletal maturity, usually don't think about giant cell tumor. Examination, you get a height, weight, BMI, vital signs are extremely important. Patients with Ewing sarcoma, sometimes they come to you with a high fever, and that high fever is mimicking osteomyelitis. So always be cautious to diagnose osteomyelitis, even in young patients, even if the patient have systemic symptoms, because we know Ewing sarcoma can present the same. Again, local examination, if there is a swelling, you look for distal neurovascular examination. Regional lymph nodes is extremely important. It can easily change your diagnosis and differential diagnosis, and even it can change the stage of the disease. You examine the chest, abdomen, and pelvis, and in older patients, you examine the breast, neck, and prostate. You do for tumor markers because you need to rule out all metastatic bone disease, and these are the tumor markers. It's good if you remember the commonest tumor markers, and for your information, you might be asked about the tumor markers in your exam. So classically 15.3 CA, 15.3 for breast. CEA is very common in colorectal and 19.9 in gastric and colorectal. PSA total and free and the ratio is important in prostate, 125 in ovarian cancers, and AFB in hepatocellular carcinoma. So, like I did my training beginning in 1998 till 2003. At that time, those two X-rays, which you know for a fact they're completely different tumors, completely different behaviors, they will be reported the same. And again, back in my training, the radiologist used to report the X-rays with this abbreviation or mnemonic. It's called Fignomashik. I actually hate this Fignomashik because you cannot put a uniform differential diagnosis for every single and each X-rays. Like this is, that this is giant cell tumor, and I know these because this is typical giant cell tumor or benign aggressive disease. We just put the laser marker. This tumor here is a giant cell tumor. It's a benign aggressive disease, while this tumor and this area is a permeative pattern of bone destruction. Is a patient of mine, and his diagnosis is an Ewing sarcoma. But back in our old age or our old days, they would be all reported as phagonomasic, which is F for fibrous dysplasia, eosinophilic granuloma, GCT, non-ossifying fibroma, osteoblastoma, Mets myeloma, aneurysmal bone cyst, simple bone cyst, hyperparathyroidism, and infection. But this to me does not make sense because you need to get a differential diagnosis that gives you a uh, very few or precise radiological classification and short list of differential diagnosis where the final diagnosis is one of them. And the only way, honestly, to do this is to have a systemic way of describing an X-rays. And that's what is the whole theme of this lecture. So this is to describe a bone lesion. This is a sum up of all my lecture. So first of all, you need to determine the pattern of bone destruction, and we'll talk about pattern of bone destruction. How is the bone is destructed? And epicenter and the site. Epicenter is where is the center of the tumor. And why do we talk about epicenter in bone lesions? Because we know that these lesions grow from a central nucleus. So that central nucleus starts as a small nodule or a small cells, and then it starts to grow in a circular fashion. So wherever that epicenter is will tell me what kind of a tumor is this. Like let's say the epicenter or the center of the lesion in the epiphysis, there are differential diagnoses of epiphyseal-based lesions like intra-articular geode, intra-articular ganglion, and chondroblastoma. So these are epiphyseal-based lesion. While if the epicenter, let's say in the cortex itself, then there are cortical-based lesions like non-ossifying fibroma, osteofibrous dysplasia, and adamantinoma. So it's extremely important to know the center site. Where is it? Is it in the femur? Is it in the humerus? Is it centric, eccentric, metaphyseal, diaphyseal, epiphyseal? Now, the zone of transition is extremely important. And cortical destruction, matrix deposition. When we talk about matrix, we mean the internal composition of that lesion. What is that tumor producing? Is it producing bone? Is it producing cartilage? Is it producing fibrous tissue? Or is it producing fluid or blood? And then periosteal reaction, which is extremely important to know what do we mean by periosteal reaction. And again, when we talk about periosteal reaction, there are two types of periosteal reaction. We have what we call malignant or aggressive periosteal reaction, and we have a benign periosteal reaction. The extent of soft tissue, is there any soft tissue involvement, and then pathological fracture, and then you comment whether the lesion is single or there are escape lesions. So if you follow this stepwise description of an X-rays, believe me, you will reach the final diagnosis very easily. So let's start first with the pattern of bone destruction. We have three types of pattern of bone destruction. Now, for your information, we stopped describing the lesion as plastic or lytic or whatever. The first thing that you comment on any lesion, that you need to know whether this lesion is destructing the bone in a geographic or a moth-eaten or permeative. Now look at here. This is geographic. By geographic, we mean that you can draw the borders of the lesion with a mouse or a cursor or your finger. Like this is geographic, and still this is geographic. The difference between A, B, and C is borders. Like here, it's surrounded by a very sclerotic rim. Here, there is no sclerotic rim, but I can still draw the borders. And here, borders are a bit hazy, but I can still see the lesion. While here is a moth-eaten. Moth-eaten, by moth, we mean a tiny little holes within the bone. And this is typically a description of multiple myeloma. While permeative is something growing, distracting the bone, but you don't know where is it, where is the beginning, where is the end. So this is called Ludwig classification of pattern of bone destruction. So remember, geographic, moth-eaten, and permeative. I'll give you a simple example. If you tell me geographic lesion, then you probably will go for a description of a benign lesion. While in moth-eaten and permeative, you will definitely go for a description of malignant lesion, because there is no lesion that's permeative or moth-eaten is a benign lesion. All of them are malignancy. So by going through the first step of bone destruction, you commit yourself toward being benign or being malignant. Again, let's describe it again. This is type 1 geographic, which is a lesion that I can draw with the cursor here, surrounded by rim of sclerosis. So this is definitely benign. Again, when you have a lesion surrounded by a rim of sclerosis, which means that the lesion has been there since long time, and typically give the bone enough time to engulf it or to build a new bone formation around it. So that behavior of this lesion is benign lesion. While this is type 2B, which is a lesion with no surrounded, it's very geographic. I can draw the borders of the region here very nicely, and it is very geographic, but there are no sclerotic rim around it. So this is type B or type 1B. And this is type 1C, where the lesion is geographic, but expanding the cortex beyond the normal cortical boundaries. And we'll talk more about this. Now, this is moth-eaten pattern of bone destruction. And typically, it's a focal lytic defects within the bone. This is tiny little holes within the bone. And this case is multiple myeloma. This is very typical of multiple myeloma. And mind you also, these lesions can occur in metastatic bone disease. This is again a permeative lesion. Like this, you cannot draw the lesion by your cursor or by your finger. It's something is growing within the bone, distracting the bone, but I have no idea where is the beginning, where is the end. And this is typically what we call permeative pattern of bone destruction. There is a lot of lysis within the bone, but it's very difficult to delineate it. But this is always when you describe a permeative, and then you're talking about a malignancy. Lesion epicenter, we talked about the epicenter. Where is the lesion? Which bone is involved? And where is it in the axial location? Is it central, mid-central, cortical? And again, if you have a metaphyseal lesion, think always about osteosarcoma or non-ossifying fibroma. While if you have a diaphyseal lesion, diaphyseal is typically Ewing sarcoma, fibrous dysplasia, and metastasis and myeloma and lymphoma, they're typically the epiphyseal. While if you have epiphyseal lesions, we talked about epiphyseal lesions, we talked about sometimes GCT, but mind you, if you look at the epicenter of GCT, usually it's a metaphyseal with epiphyseal extension. Also, geode, which is subchondral cyst formation in patients who had osteoarthritis. Infection also can happen in the epiphysis. Chondroblastoma, also epiphyseal. But you also have to remember what we call clear cell chondrosarcoma. And whoever who worked with me in the rotation, we always show you some typical examples of a clear cell chondrosarcoma and how to differentiate between clear cell chondrosarcoma and chondrosarcoma based only on X-rays and MRIs without even going into biopsy. Cortical lesions, if the epicenter within the cortex, this is typically non-ossifying fibroma or osteoid osteoma. The epicenter of the lesion is within the cortex. Parosteal osteosarcoma is in the parosteal lesion, parosteal tissue. And what do you mean by parosteal tissue? It's a very specific fibroadipose tissue localized in only 3 sites: posterior distal femur, posterior proximal tibia, and medial proximal humerus. Again, this is a sum up of all what we talked: central, eccentric, cortical, juxtacortical. And these are the lesions that occur in the epiphyses and diaphyses and the epiphyseal lesions. Lesion location, again, is very important. Again, axial locations or appendicular locations. In axial locations in the pelvis, it's always abnormal. So think in patients who are young, think about osteosarcoma. Older patients think about chondrosarcoma, lymphoma, Ewing sarcoma, chordoma is common. And distal radius, keep GCT in your mind. Always GCT. Most of the cases in distal radius tumors are GCT, and typically they're much more aggressive than GCT around the knee. While osteosarcoma and Ewing sarcoma typically occur around the knee. Tibial shaft, these are the 4 important lesions in the tibial shaft: non-ossifying fibroma, fibrous dysplasia, adamantinoma, osteoid osteoma. And for your information, in spine tumors, most of the anterior spine lesions are malignant, while the posterior spine lesions are typically benign lesions. Of them, the most commonest is osteoblastoma, osteoid osteoma, ABC, osteochondroma, and CMF or chondromyxoid fibroma. But if you see any anterior bone lesion in the spine, which is in the body, then the chance of this being malignant is much more higher. Now look at the zone of transition. This image here is the female patient, 22 years female. She presented with knee pain. So if you look at the lesion, this is a geographic lesion, but I can clearly define the normal from the abnormal. So this is a narrow zone of a transition. When you have a narrow zone of a transition, then you're talking about a benign lesion. While if you have this patient, he's an 11 years male patient, he presented with left thigh pain, and you know that there is a lesion here. To me, it's permeative. I know there is something growing. There is lysis within the bone, but I don't know where is the normal from abnormal. Is this normal? Is this normal? Is this abnormal? Is the neck normal or abnormal? So this is what we call wide zone of a transition. And that wide zone of transition gives you an indication or another proof that this is probably not benign. Now let's look at the cortical destruction. This is what we call neocortex. And let's agree on something. Always look at the radiology as a reflection of the behavior or the biology of the tumor. So by this neocortex, if we talk about neocortex here, this here is neocortex. Neocortex, this is by the name says neo means a new. So basically, it is not the patient cortex. It's a new cortex. So the patient cortex is right at this area, while this is a new. So the pathology or the behavior of this lesion, that the lesion is aggressive lesion, it destructs the cortex completely and start lifting the periosteum but wasn't enough to penetrate the periosteum. So, and the periosteum start to be lifted off and expanded up beyond the cortex. And that periosteum, because it's raised off the bone and still continuous, start forming a neocortex, which we call neocortex. So this neocortex is a sign of being benign, while here complete cortical destruction, I do not see any cortex at all. So this is a sign of being malignant. Here in this lesion, it's a geographic region. It's not destructing the cortex, but if you look at the endosteal surface from inside, this is what we call endosteal scalloping. So translate this into biology. This is more active, but still not malignant to destruct the cortex. Now, going to matrix deposition, again, we talked about what is matrix. Matrix is the internal composition of the tumor. So what is the tumor is laying down? So again, we said it before, it's either laying down bone or cartilage or fibrous tissue. But the two most important matrix deposition is laying down bone, which we call it ossification and calcification. If we go back to basics or histology, what is the difference between ossification and calcification? The very important difference, which is the presence of a cartilage analog. So if you have a cartilage analog, then we talked about calcification. If we have no cartilage analog, so bone formation without a cartilage analog or cartilage base, this is ossification. Let's think about ossification, or let's talk about calcification first. We know by histology, if you still remember histology, the cartilage grows in lobules. Okay, so it grows in circles or lobules. If you have a tiny little calcifications within the center of these lobules, you get these what we call stippled appearance. شكلها زي النقاط. While if you have a calcium deposition around the periphery of the lobules connected to each other, we call the flocculent. While arcs and rings, which is the O and C, letter O and letter C, this is a typical of cartilage or calcification, where the calcification occur around the whole periphery of the lobule. Whether it's a complete will give you a ring, or incomplete will give you an arc. So remember all these three, stippled, flocculent, and arcs and rings. This is a description of calcification. So when you tell me I have a malignant or I have permeative lesion with evidence of calcification, then you have to go through a malignant cartilage producing disease. While if you tell me this is a permeative region, which is malignancy with a very wide zone of transition and ossification, then you have to go through malignant bone forming disease like osteosarcoma or osteoblastoma. Now, solid ossification, it could either be solid, a very dense, solid whitish structure, or cloud-like, or ivory, more whitish, which is laying down bone. But the difference between here, cartilage and ossification, again, there is no cartilage analog. Lucent or lytic, we stopped talking about this, but you can always describe it in patients above age of 40. And again, mixed matrix, this is another terminology, but you don't have to know about it. So now look at these three cases of our practice. This case is a 22 years male patient. You know there is a bone lysis and destruction inside. You don't know where is the beginning, where is the end. And it's a permeative, very wide zone of transition. And look at the whitish structures here. These whitish structures here are, or whitish matrix, is bone forming lesion. And the diagnosis of this patient was high grade conventional osteoplastic osteosarcoma. While this female, she's a 22 years female patient. I don't know if the image is clear for you or not. It's a geographic. I can always agree with you if you tell me geographic, but there are arcs and rings in between. There are arcs and rings. There is no calcification. There is no whitish. There is no ivory, no solid matrix deposition, but these are arcs and rings. And this patient turned out to be grade 2 chondrosarcoma. And here in this patient, we have these flocculent appearance. And this is for whoever of you wanted to do a sport or shoulder upper extremity fellowship, you will see these lesions very frequently because the commonest location of these lesions is in the proximal humerus. This is a fluctuant calcifications in a benign lesion, a geographic lesion, would tend out to be a typical cartilaginous tumor. Are we okay till now?
I don't have any questions in the chat, so I think so.
Okay, great. So periosteal reaction, what do you mean by periosteal reaction? It's the response to the periosteum to the underlying irritation. Again, think about the biology. Always when you see any X-ray, think about the biology. Any periosteum is lifted up from the bone lesion, it will lay down a new bone formation. Whether you lift the periosteum because of you're doing a surgery, or there is a fracture, or there is a hematoma, or infection, or a tumor, the periosteum secondarily will start forming bone at that point. And it depends whether that lesion is expanding, is distracting the cortex, very aggressive, it will penetrate the periosteum from the center and leave the periosteum from the edges intact. And this is where it starts laying bone formation, and we typically call it Codman triangle. While if this lesion is not malignant and is a very aggressive lesion, like benign aggressive lesion, it will distract the cortex, lift the periosteum, but it's not malignant to penetrate the periosteum. So the periosteum will stay elevated away from the cortex, and at that point it will start to form a new bone formation, which we call it neocortex. So these are the types of periosteal reaction: solid, which is benign in cases like osteoid osteoma, or if there is a fracture, the body start to buttress, or if there is a non-ossifying fibroma in the cortex, the body started to buttress. So it will start forming a very solid looking periosteal reaction. While laminated, which is typically occurs in Ewing sarcoma, and spiculated, this is an aggressive periosteal reaction, and very aggressive is the Codman. The most aggressive is the Codman triangle. So looking at this is buttressing periosteal reaction. If you look at this is an osteoid osteoma with buttressing periosteal reaction. This patient, again, is my patient, is a periosteal reaction, and you look Codman triangle, very small Codman triangle. There is multi-layer periosteal reactions over here, and this is Ewing sarcoma. And this patient is one of the very first patients that we treated. She's a female patient, and this is Codman triangle. Like if somebody looks at this X-rays in a GB clinic, probably he will discharge her. He will tell her, listen, this is a growing pain in your arm. There is no abnormality, no fractures. If you look carefully, or if you zoom it out a little bit, you could see there is some lysis inside the bone. And this periosteal reaction could be the first or the only sign of being malignancy. And this patient turned out to be Ewing sarcoma of the midshaft of the humerus. And this patient also that we treated him 2 years ago or 2.5 years ago, you could see that this speculated or the sunburst appearance here. And this is a very aggressive looking periosteal reaction, a Codman triangle down in this area and also in this area. So this is the way how you differentiate between a solid or buttressing type benign bone lesion from a malignant looking bone lesion of Codman triangle and multi-layer periosteal reaction. Now, soft tissue component is typically indicated a malignancy, but can also be seen in benign aggressive disorders, and we will talk about what do you mean benign aggressive. Okay, it is not visible on X-rays unless it is calcified or ossified, but you might see distortion of the fatty planes and muscle planes. So just always keep an eye on the muscle planes and fatty planes. Look at this X-ray. This X-ray is one of our patients also. This is a very destructive lesion. It's a permeative pattern of bone destruction with typical Codman triangle here, periosteal reaction, cortical destruction. And this patient turned out to be osteosarcoma. And again, this is the MRI. Sorry, I put it in the other way. This is the MRI of this patient. You see, after he got a fracture, and then this is a soft tissue mass. And this patient is the X-rays of the MRI of the patient with the fibular Ewing sarcoma. Look how the extent of the soft tissue component around it. So if you see a patient who had a soft tissue mass, then always think of malignancy. Okay, now by far, this is the second most important slide that I need you to remember. Now, there is always an intermediate step. After you run through that exercise of describing this X-ray, I need you to come up with these four descriptions, okay, of any X-ray. You think about a benign lesion, which is benign latent, or this is a benign active disease, or a benign aggressive, or potentially malignant. So when we talk about aggressive, for the residents who work with me, the word aggressive لا تعني malignancy. The word aggressive is a description of a behavior of a benign lesion, while potentially malignant, because it is still potentially malignant. We did not diagnose the patient yet with cancer. So this X-ray is potentially malignant when the lesion is moth-eaten on permeative pattern of bone destruction, when we have a wide zone of a transition with cortical breakthrough, aggressive periosteal reaction, soft tissue mass. So this is all the description of potentially malignant. Now, benign latent, go back to benign latent. Benign latent is again is the geographic or well-demarcated lesion, and it's surrounded by a good rim of sclerosis, slowly growing. Latent معناه has been there since long time and gave the bone enough time to engulf it or to contain it with enough sclerosis. While active, which means a very geographic lesion, but may show cortical thinning, which we call it endosteal scalloping. And we described it before as Ludwig type 2, type 1B. Okay, while benign aggressive lesion, these lesions are associated with the neocortex formation. So the lesion is still geographic, however, it distracted the cortex and lifted the periosteum, but wasn't malignant enough to penetrate the periosteum from the center, and the periosteum start to form bone formation. Again, think about the biology explains the radiology. So a biology which is latent explain a very well demarcated lesion, while a biology which is aggressive, and we'll talk about the aggressive disorders, it distracts the cortex because it's aggressive. However, it's not yet malignant to penetrate the periosteum and to give you the Codman triangle. The bone started to form under the surface of the periosteum and gives you what we call the neocortex. And this is the differential diagnosis. Okay, so when you go with the benign latent lesion based on X-ray, you give me these differential diagnoses. When you give me benign active disease, UBC is the most commonest benign active disease because geographic, it causes, you see, I'm sure you saw so many cases of UBC. It gives you endosteal scalloping. In chondroma, sometimes usually it's a benign latent, but sometimes it goes into benign active disease where it starts to involve the cortex, and fibrous dysplasia is one of the best examples of benign active disease. Now, benign aggressives, these are the typical lesions of benign aggressive disorders. And whenever you describe an X-ray, you found this neocortex formation, the hallmark of benign aggressive disorder is the formation of neocortex. Sorry. And the differential diagnosis is GCT, aneurysmal bone cyst, chondroblastoma, osteoblastoma, CMF or chondromyxoid fibroma, telangiectatic osteosarcoma. So these lesions, you have to put them when you describe a lesion with neocortex formation. And then according to your knowledge and your studies and your information about every single disease, you can prioritize, or you put the GCT on top or you put it in the bottom. Potentially malignant lesions, you know, osteosarc, chondrosarc, Ewing, Metz, myeloma, lymphoma. Always remember, infection and eosinophilic granuloma are the great masqueraders. So you always put them in the differential diagnosis of any lesions. And eosinophilic granuloma typically goes in or typically comes in patients less than 5 years of age. So again, if you remember this, biology will explain your radiology. Inshallah, you will never miss any radiological classification. Now we go further from X-rays to computerized tomography scan. We measure, it's a measure of the density of the lesion. And you can look for the fine cortical details. I'll give you an example. If you have a lesion that you're not yet sure, especially in the distal radius and the distal and around the knee, If you have a lesion that you're not yet sure whether this lesion is a malignant or benign aggressive disorder, because you cannot see the neocortex, you may do an CT scan to look for that neocortex. And this neocortex, if you see it, you're 100% sure that this lesion is benign. Okay, because again, biology will explain the radiology. And typically, all pelvic tumors have to have a CT scan because this is the best way to look for neocortex formation. And for your information, GCT is extremely common in the pelvis, and sometimes it is a very diagnostic dilemma to diagnose a GCT or a giant cell rich osteosarcoma. So if you do a CT scan, and you find the neocortex, you say, okay, this is a GCT because I know the behavior of GCT. The second example, to assess whether these calcifications or ossifications, especially if they're very minimal and minute, especially in the pelvis, you do a CT scan and you look for these lesions. Are they calcified or ossified? Another example is chondroplastic osteosarcoma, which is a high-grade conventional osteosarcoma, versus chondrosarcoma in patients like 25, 30 or 40 years of age. If you do a CT scan and you find calcifications, then you go for a diagnosis of chondrosarcoma. If you find ossification, you go with the diagnosis of osteosarcoma or chondroplastic osteosarcoma, which can sometimes be really difficult to differentiate based on pathology alone. So the pathologist tells you, please correlate with radiology. And again, we talked about detect pseudocortex formation in areas where there is a GCT, probably, and we can talk about GCT in another lecture. There is another type of GCT that we call grade 3 GCT, where is there complete cortical destruction on X-rays. So the way to detect whether there is a pseudocortex or neocortex formation is to do a CT scan. So magnetic resonance imaging is extremely important MRI. And again, always MRI, look at the nature, behavior, and anatomy. This is the three important things that you need to look at the MRI. There is a specific way of reading MRI in bone tumors. When you talk about behavior, let's say you described a lesion as benign active or benign aggressive disease. And when you look this lesion here, probably you will tell me there is a geographic lesion right there. So I may go for benign active disease. But when we do an MRI, you look for the huge soft tissue mass, cortical destruction, and invasion everywhere. So now I upgraded the behavior from benign active or benign aggressive to being malignant. Now, nature of the lesion, by nature of the lesion, we can easily know the differential, the diagnosis. Like this lesion is a benign active disease. Benign, it looks benign active. There's probably mild periosteal reaction, maybe yes, maybe not. But when I did an MRI, I know that the lesion break the cortex from here, and this is a soft tissue mass. So I now upgrade the lesion from benign active on X-rays to potentially malignant in MRI. And also, if you concentrate more, you'll see multiple fluid levels within the lesion. So this gives me an indication this is a malignant disease and it is telangiectatic osteosarcoma. So these are typical examples where you can upgrade the lesion on X-rays, on MRIs, and another typical example where you can easily diagnose a bone cancer like telangiectatic osteosarcoma based on MRI. But I'm always telling my residents when they come to me, probably the radiologist, when he look at the way we read the MRI in orthopedic oncology, he will not be happy. You say, okay, this is a very primitive or simple. But I can tell you, we can reach the diagnosis much more quicker than a radiologist reach it. And when the radiologist write his differential diagnosis, the differential diagnosis will include benign, malignant, everything. But in our reading, we should be able to determine on X-rays and MRIs what kind of disease we're dealing with. Anatomy, this is another reason why we do the MRI, to look at the anatomy of the lesion. Where is the lesion located within the bone? This is a lesion located in the proximal tibia, in the posterolateral aspect proximal tibia. It looks like an osteochondroma because of the corticomedullary continuity and anatomy. You know where is the lesion located, proximity to neurovascular bundle, which muscles are being invaded, which muscles are being pushed. And then Important to know that you need a full length of MRI, full length MRI, and also it has to be contrasted images. Whole body bone scan is extremely important for staging of the disease and also important to detect any escape lesion. This patient, I know this patient, she came from outside the kingdom. She was referred to me as a case of distal femur osteosarcoma with a malignant lesion where they did the wrong biopsy, and we did for her a distal femur replacement using an expandable prosthesis. She came later on with bone pain in the other side, and unfortunately she had another bone lesion here in the femur, which is typical of metastatic deposit or bony metastasis. For whole body bone scan, for your information, we give technetium-99, and it's absorbed in newly formed bone or high turnover area. But also it can show you high vascularity, it can detect skip lesions. It can also be an indication of the response to treatment. If you look at this bone scan, this is a primary bone tumor, and following chemotherapy responded nicely to chemotherapy. PET scan, the most commonest radio tracer we give is fluorodeoxyglucose. It's a glucose analog labeled with radioactive PET emitting fluorine 18. It's used to detect metabolic activity. It's important for metabolism. So any lesion that's highly metabolic, it gives you a very high standard uptake value. And typically we compare this to standard areas. And for prostate cancers, because they're not highly metabolic, and lung cancer, they're not usually effective. But it is the now the current data shows you now this is the number one study that gives you the high positive yield if you have any bone lesion above age of 40 and you wanted to stage the patient looking for primary. You do a PET scan, it can show you everything. It can show you the brain. If there is metastasis, it can show primary bone, primary lung, primary thyroid, primary breast, primary GI, or prostate cancer. So it can show you the primary disease as well as it also can show you the metastatic deposit and lesions everywhere. We typically use in primary bone cancers, we use it in Ewing sarcoma because we know Ewing sarcoma tumors, they can go to the lymph nodes, they can go to the bone marrow. So typically we use PET scan, and it can also be used in primary bone lymphoma because the lymphoma is very specific for PET scan and can also detect the response to treatment and local recurrence. The value of PET scan on osteosarcoma is very questionable. And again, we talked about primary carcinoma and metastatic bone disease. And if you again look at the literature tells you use the PET scan. It's very effective or very efficient to detect the primary carcinoma. Now, CT angiogram, it's very important to outline the vascular structures. We use an arterial, venous, and reconstruction views in all axial, sagittal, and coronal images. And if there is a need to do angioembolization before the surgery or before the surgery or not, you could see because one of the very important features of being a tumor is the power of angiogenesis. So if you find there is a tumor blush, what we call a tumor blush by CT angiogram, we tend to go for preoperative angioembolization to decrease the amount of blood loss. CT chest also is very important. It's usually non-contrasted CT chest. It detects the lung cancer. And again, remember, PET scan, part of it is CT chest. And in staging of any bone cancer, you don't need to do an abdomen and pelvis CT. It's only CT chest. And for your information, one of the very recent articles that was published at the end of 2025, they have said that more than 30, I think I cannot guess the number, it's more than 30% of patients diagnosed with cancer, they have been subjected to a CT scan prior to their diagnosis of CT. Why? Prior to their diagnosis, they were subjected to a CT scan, and they have postulated that probably CT scan increases the incidence of cancer in the population. So you really have to be cautious in ordering an abdomen and pelvis CT scan in staging of bone cancers. Again, bone biopsy, you need, again, we talked about potentially malignant. It's not yet malignant. We are assuming that this is malignancy. So we need to diagnose this malignancy. And also in aggressive bone, benign aggressive bone lesions, you need to take a biopsy, and also any solitary lesions in patient with history of cancer. And this is the typical bone biopsies that we do. Commonly in bone cancers, we do core needle biopsy. So we take a true cut biopsy. It's a thin needle biopsy. It's a core. So we have to take a core of that bone is used for sarcoma. FNA is typically not done in sarcoma. We do not usually do an incisional biopsy unless if we have failed image-based biopsy. Excisional biopsy in bone cancers is not indicated. And the principles, I think everybody knows what is the principles of bone biopsy. Again, it has to be through the same incision where the planned surgery is being planned, and it has to be through the involved compartment, away from neurovascular structures. And you really need to maintain meticulous hemostasis, especially if you wanted to penetrate the bone. Frozen section is extremely important. It's not to diagnose, it's rather to know that this is a legional tissue or not. And also always try to take the biopsy from the soft tissue rather from the bone lesion, because whatever in the soft tissue is representative of the bone lesion. And think about it also, the biology of the soft tissue is more representative because the tumors, when they grow rapidly, they undergo a central necrosis. So the periphery is usually more representative. You bring the drain in line with the surgical skin, not far away from the surgical incision. And also, again, as a principle, you biopsy what you culture and you culture what you biopsy. And typically, we go for AFP, fungal cultures, and routine bacterial cultures. Just to complete the story, musculoskeletal tumor society staging, stage 1, 2B, stage 1, 2, and 3. 3 is metastatic disease. Stage 1 is a low-grade tumor, what's intracompartmental or extracompartmental. And stage 2 is a high-grade disease, whether it's an intracompartmental or extracompartmental. Typically, most of our patients, they come with a stage 2B disease, though unfortunately we have a high incidence also of being metastatic disease due to the late presentation, and unfortunately also due to the late referral or delayed referral of these patients. And to tell you the truth, one of the most commonest causes of delayed referral is probably the diagnosis of what we call growing pain in children. Like, we've seen so many cases where patients, they keep presenting to the doctors, whether primary care or orthopedics, as pain in the knee or pain in the upper extremity, and the diagnosis is just growing pain. Even if they, like, even I've seen cases where they did x-rays and they were unable to detect these tiny periosteal reactions, and guess what? It's an osteosarcoma. So let's go through a clinical exercise of some cases of our practice during the past 20 years. This is this one patient. He's a 22 years male patient. He had a dull aching pain 3 times, fracture in the same location. This patient, I know him, he fractured in the same location, and all his fracture healed. And the issue is that this patient, he went to many orthopedic surgeons. They put a cast for him. They treated him as just a pathological, just a fracture. And these ossification, nobody paid like a major attention. This patient had fracture 3 times. And so what is your differential diagnosis? If I look at this X-ray, there's a perimeative pattern of bone destruction. There is an ossification in the center here, and there is a soft tissue mass. So to me, this is malignancy, potentially malignant lesion. So now when I talk about potential malignant lesion laying down bone, then I know this is osteosarcoma. Okay, and if you look at the MRI, there is obvious soft tissue mass and osteosarcoma. Typically, intentionally, I put these pathology images for you just to prepare you for your exam, probably because you will get some pathology images. Now, let's go back to this X-ray. If you look at this X-ray, I know from the clinical history, this young patient in the second decade of his life, he had chronic pain, and that X-rays are permeative pattern of bone destruction, ossification. So in my mind, this is osteosarcoma. So this is, to me, it's an added point to prove that my thinking is correct. Okay, it's not, we're not here to test your knowledge in pathology. Okay, but if you look here, these cells are very abnormal. They look really different. So different cellularity, hypercellular, there's a giant cell here, and this stuff in the center is the malignant osteoid formation. So the case was osteosarcoma, non-metastatic osteosarcoma, and the standard treatment is neoadjuvant chemotherapy, surgery, which is wide local resection and proximal tibial replacement, and he goes for adjuvant radiation therapy, chemotherapy. So this the entire proximal tibia is resected, reconstructed, medial gastrocnemius flap. This is his X-ray. Case number two, this is one of the very peculiar case in my practice. I think I will never ever forget this case. This is a 5 years old female patient. Again, I told you from the beginning, her father is the musculoskeletal radiologist in my sarcoma team, and his daughter fell down at school, and she was immediately taken to one of the closest hospitals. They did X-rays, and they talked to her father. They sent the X-rays for him. And in the beginning, we said, okay, let's refer the case for another facility because, like, her father works with us in the hospital. He refused. He said, okay, listen, I want to get my daughter treated here. So if you look at the X-rays, there is a permeation. I don't know if it is clear or not, but there is evidence of permeation and multi-layer periosteal reaction. If you're not sure, do an CT. We did the CT scan. There is permeation in the cortex, and there is also flary cortex here, and there is periosteal elevation and Kudman triangle. So from the first time you look at the X-rays, you know that this is a malignant disease. Okay, and what malignancy occurs in a 5 years female patient? It's typically Ewing sarcoma. So Ewing sarcoma, by definition, is small round blue cells. Okay, small round blue cells. These are the brown blue cells, homogeneous, small and round. They have hyperchromatic nuclei. You don't have to know about this, but remember, small round blue cells. So she underwent neoadjuvant chemotherapy, and then she came for local control. We did the total humerus replacement in a 5 years old, which looks weird, expandable because of we were afraid from limb link discrepancy, and adjuvant chemotherapy. This is her standard surgery. It's an anterior deltopectoral approach where all the neurovascular bundle is dissected. There's a radial nerve, this median and radial, this is ulnar, and this is brachial artery, and here and here is the median. And if you concentrate more, I can show you the axilla with provenance not clear. And this is the radial nerve, and in the entire humerus with the biopsy taken out completely. And then we put the prosthesis inside. It's a total humerus prosthesis. All the muscles were repaired back into position, and this is her X-ray post surgery. I can show you her video. I don't know if the video works or not, but the video, like, it's amazing. MashaAllah, she's able to go up and down using her extremity quite almost normally. Oh yeah, this is the video. So you can barely tell which one is involved. It's the left side, by the way, but she's able to use her shoulder, able to use her elbow very nicely. This is another example. She's a 42 years old female patient, previously healthy. She had a chronic wrist pain and swelling. So if you look at the X-ray, I can always accept if you tell me a permeative pattern of bone destruction with complete cortical destruction over this area. But again, I told you from the beginning, always look at the whole picture, not only the permeation, look at the periosteal elevation. So rarely often you get a tumor or a malignant tumor with no periosteal elevation. And in the distal radius, always consider giant cell tumor as part of your differential diagnosis. In your readings, there is a type of GCT that we call it Campanacci grade 3. So this is Campanacci grade 3 giant cell tumor. And this lady, I remember she came in the beginning where the women are allowed to drive. So all her concerns, I want to drive my car. I bought a car, I need to drive my car. So we diagnosed her as biopsy-proven GCT, and because the tumor, there are no boundaries of the tumor right there, we started her on denosumab, and she had an excellent improvement. By the time she had an improvement, she disappeared completely for 6 months because she bought a car, she wanted to drive, and she stopped her denosumab. But later on, she came with the major progression of her disease, and then we restarted denosumab again. She had a complete destruction of the entire distal radius. Look at the denosumab, the power of denosumab with the formation of the cortex. And then we have to do a complete resection of the distal radius. And we also, if you concentrate here, we bypass the radial artery because she was radial artery dominant. We did an Allen test and intraoperative testing also. We found the radial artery is dominant, so we did a radial artery bypass. We took the entire distal radius together with the proximal row and part of the distal row. We took the entire row completely. We ended up with the metacarpals here. And if you also look, we transferred the ulna. We did the vascularized ulnar transfer and centralized it to the mid radius and to the mid rest, and we did the anastom or did the docking site, or we connected the remaining the ulna transfer to the remaining distal radius, and she did really very well with an excellent function. We did, by the way, complex tendon transfer. We transferred the flexor carpi radialis to the extensor digiti communis and also pronator to, so multiple tendon transfers. She ended up with a good flexion and good extension. She's currently doing well, no evidence of local recurrence. So if you look at this patient, he's a 17 years old male patient, pain, dull aching. What is the differential diagnosis? So we're looking at this X-rays. This patient has a benign active disease. His MRI showed a very high signal intensity in T2, and this is typical of benign active disease, which is unicameral bone cyst. So the treatment of unicameral bone cyst, we always like to decompress. The literature is full of methods how to treat unicameral bone cysts, but we elected to choose one and only method, which is just decompression using two flexible nails, and he had a marked improvement and complete resolution of his unicameral bone cyst. Another case, a 17 years male patient, pain in the distal femur. She was actually she was engaged, and she started to complain of left thigh pain. And when they did an X-rays, they found an abnormal lesion. So this is a saucerization, or we call it apple core appearance. If you look here, there is a periosteal, faint periosteal reaction. And if you look furthermore here, you could see that there is evidence of Codman triangle. Look at the MRI. The MRI showed you a huge soft tissue mass at the midshaft of the femur. And again, small round blue cells typical of Ewing sarcoma. She had neoadjuvant chemotherapy and radiation therapy because she had no response to chemotherapy on upfront chemo, so we have to give her radiation therapy. And then she underwent wide local resection with intercalary reconstruction. So the tumor was approached through lateral approach, and then the tumor was completely taken out with the engulfing soft tissue mass. An intercalary custom made or 3D printed implant was put for her. It's a 20 centimeter resection, and this is her reconstruction. And this surgery was done somewhere in like 6 years or 7 years ago. I've seen her a month or 2 months ago. She got married and she had one daughter. She's living happily without any local or systemic recurrence. So another patient, he's a 12 years male patient, has a trivial trauma, subsequently complained of severe pain. And typically, if you look at this X-ray, you know that this is malignancy. There is permeative pattern of bone destruction, periosteal reaction. So we immobilized him, and the differential diagnosis of any malignancy in pediatric population is osteosarcoma, Ewing sarcoma. In more older population, we add bone lymphoma infection, e.g., of course, but turned out to be osteosarc, and he developed a fracture that healed after chemotherapy. And again, osteosarc, this is the osteoid formation, and these are the malignant high-grade anaplastic cells. Anaplastic means they're large, hyperchromatic, and different shape and size. And he had a wide local resection, expandable tumor prosthesis, and this is his tumor, was taken out completely, and expandable prosthesis. You could see that the prosthesis we started growing him, and I just saw him today. He's 9 years or 10 years status post surgery. He's doing quite well right now. And this is his video. This is like 10 years after his surgery. He's walking well. By the way, I'm sorry to show the face, but he was consented for this. I couldn't, I'm different generation than you. I couldn't, I could not, blur his face. There's another case, a 32 years old female patient. She had a dull aching pain for 5 months, and she works as a teacher. Whenever she left her arm up, she complains of pain. She was referred to me from another private hospital and looked at the x-rays. This is from the beginning, you could say this is benign active, but furthermore, you look, there is a periosteal, faint periosteal reaction. So this is malignancy. And when we looked at the MRI is a very high water content in T2, which is highly suggestive of cartilage cell. So we took the biopsy. It turned out to be grade 2 chondrosarcoma. And look, chondrosarcoma, usually this is chondroid matrix, and the clear cytoplasm and cells are very different from each other. Okay, and no surgery, no radiotherapy. It's only wide local resection. So tumor was taken out completely. This is the neurovascular bundle. This is the musculocutaneous nerve going through the biceps. This is the axillary nerve around the inferior border of the glenoid, radial nerve right there. Tumor was taken out completely and reconstructed back again. This is the closure of the area here. And this is, we did the reverse shoulder arthroplasty on a proximal humerus. And currently she's 4 years, I think 4.5 years, and she's doing quite well. It's another case, which is 16 years old male patient. He's one of the lucky patients I have. Yeah, not lucky because he had a cancer, but lucky, I'll tell you the story. He had pain over the right thigh for a few months. And when we looked at the x-ray, he had a past trauma. But when we looked at the x-rays, there is evidence of periosteal reaction, soft tissue mass, sun-pierced appearance, Could-Bennett triangle. So this is typical malignancy. He had no constitutional symptoms, so our differential diagnosis is potentially malignant lesion, most likely Ewing sarcoma versus osteosarcoma, but it turned out to be Ewing sarcoma. So he had a chemotherapy, local control, post-operative chemotherapy. What we did, this was the first case to be done here in the kingdom as a case of extracorporeal irradiation and reimplantation surgery for bone sarcoma. So the tumor was excised completely, soft tissue component was removed and sent for pathology. The bone was taken immediately while during OR, it was irradiated, and then we reimplanted it with the fixation. So this is a tumor approach through lateral approach, taken out completely, and then we through a separate table, the periosteum was incised longitudinally and cleaned completely, wrapped many times, and sent for radiation. There is an actual image of the patient, and then we brought back the bone after irradiation. We reimplanted back again in the femur, and this is his final. This is his initial X-rays. This is the docking site or osteotomy site, and this is his final X-rays. Complete healing at the proximal docking and distal docking site, and also he's lucky because um, he was called from Al Imara and he was awarded so many things. And now I think he's curing his future. Though he had a cancer, alhamdulillah, he's completely free from his disease. But he was celebrated by Imara and Minister of Health and Prime Minister in Riyadh and so many things, because this was the first case to be done in the kingdom. Case number 9, this is an 18 years old female patient, pain in the posterior aspect of the knee for a few months, no trauma, no constitutional symptoms. If you look at this lesion, there is a lesion right there in this area. And if you look careful in the x-rays, this lesion is ballooning the cortex, right? There is a neocortex formation right at this area. So to me, this is a benign aggressive lesion because I can see the borders here of the lesion. So it's benign. And I see neocortex over there. So this is neocortex, benign, aggressive disease. And if you concentrate also, the epicenter is in the epiphysis. So out of the 7 lesions that are benign aggressive, chondroblastoma is the one that occurs in the epiphyseal region. So looking at this X-ray, I can assure you this is chondroblastoma. This is chondroblastoma. Okay, so when we did an MRI, we know that this is chondroblastoma. Now, I'll give you just a simple hint how to differentiate between, it's not our subject here, but it's just because I showed you this MRI. Chondroblastoma gives you a very wide bone marrow edema around the tumor. Well, if you need to look at clear cell chondrosarcoma, which is another differential diagnosis of epiphyseal-based lesion, typically there is no perilesional edema, which is exactly the other way around. Like it's contrary to what you think. Clear cell chondrosarcoma does not give you bone marrow edema, while chondroblastoma, like this lesion, gives you too much bone marrow edema. And again, the chondroblastoma gives you like typical appearance of chondroid and fibrous tissue and chicken wires and stuff like this. So the treatment is intralesional curettage because the lesion is very close way at the back. We did like intralesional image guided and endoscopic curettage of this lesion. We use the endoscope. We put the endoscope right there. We went inside, we clear it, and we put bone. See, this is the cartilage. Like the image on the left, you can see the video. This is, I put the camera and I put the curette inside. We cleaned everything through the camera. And then we use the argon beam diathermy to clear the cells, the cartilage in there. And then we put a bone graft substitute. This is the argon beam diathermy. Look, the white stuff here is the cartilage. It was not penetrated. And then we did the bone graft substitute, which is currently 4 years post surgery or 5 year post surgery, is doing very well. Now, the last case is an 8 years female patient. She had a long-standing pain and swelling in the tibia. So if you look at this, this is a permeative pattern of bone destruction, and this is an ivory. So permeative pattern of bone destruction is malignancy, and ivory is bone formation. So this is osteoplastic osteosarcoma, and this is an osteosarcoma or high-grade osteosarcoma, but I can easily go further beyond to go into deep histopathological classification to tell you this is an osteoplastic because it's laying more down bone. Okay, now this patient 8 years and she was non-metastatic. Her MRI, this was her MRI. The family refused completely to get any treatment, and she came like 9 months later with this huge, massive blowout of her proximal tibia. And this is later on, we offered surgery at that point. At here, we offered her chemotherapy and surgery. Again, they refused. They went for traditional medicine and stuff like this. And they came to my clinic with this huge soft tissue lesion, complete destruction. And look at this fungating mass over in this area. And she underwent emergency above knee amputation. Unfortunately, she developed metastasis, and as far as I know, we took her metastasis out from her lung, and she's currently living with an amputation. So, in conclusion, the clinical, radiological, and pathological evaluation is extremely important. You need to get systemic approach to X-ray evaluation. Do not forget to go all through the steps from the beginning till the end, and you come to an intermediate step where you classify the region as benign latent, benign active, benign aggressive, or potentially malignant, and you put a logic differential diagnosis. Like I cannot accept to put a non-ossifying fibroma with osteosarcoma. I cannot accept to put chondrosarcoma versus osteosarcoma. And again, remember, biology reflects the radiology. Always when you describe a radiology, think about the biology, and you need to have a strict adherence to biopsy taking protocol. By the end, I conclude my presentation, and thank you so much for listening. So if you have any questions, I'm very happy to answer.
في بعض الأسئلة دكتور منها is there a difference between permeative and wide zone transition or both of them towards an ill-defined lesion?
هلا كلمة permeative, when we talk about permeative, we talk about the pattern of destruction. Permeative means something is growing inside. By default, يعني wide zone of transition. But this is not the same terminology. Okay, so I could easily have, I give you an example. An example is metastatic bone disease. Usually they are geographic. If you have a bone, like a lung cancer, it goes to the femur, gives you geographic lesion, but the zone of transition is wide. You get my point? While permeation is a pattern of destruction, is not a transition from normal to abnormal. واضحة النقطة؟ Can see a question, why, what is frozen section? Why frozen section is important? Now, in all bone tumors, you need to send a frozen section to know whether whether you're taking a lesion or you're not taking a lesion. Is this biopsy is legional or not legional? Okay, and you send it for the pathologist. The pathologist will reply to you in 10 to 15 minutes. He will tell you, yes, you are inside the region, then you close. You don't need a diagnosis. You defer the diagnosis for the permanent section. Is there a difference between permeation and wide zone of transition? Yes, we talked about this. Permeation, again, is a pattern of destruction, while zone of transition is the transition between normal and abnormal. How stress fracture appears as malignant in histopathology. Okay, I gave you the example. Now, stress fracture, because it's a stress fracture, it will develop callus formation. And osteoid is by itself is can be seen in osteosarcoma and can be seen in cancer cases. Now, the differential diagnosis here has to go back to clinical and radiological evaluation. If you tell me that his x-rays, his clinically he had a trauma, this patient had a trauma, and then mechanical pain rather than inflammatory kind of pain, and when you look at the x-rays, you look at the whole circumference of the bone is involved by buttressing callus formation, and you correlate it with the pathology, then this is a stress fracture, not osteosarcoma. And we have, like, I can remember in my practice, one of the cases I will never forget, she had an above knee amputation for stress fracture. Any tips not to miss a malignant tumor when impression is growing pain? This is a very excellent question and extremely important. And I always stress on this point, never ever diagnose a patient with a growing pain unless you rule out all causes of pain. Okay, so it's a diagnosis of this seclusion. The most important thing is not to ignore the patient and not to discharge him from the clinic. Okay. Now, again, we all look for guidelines in our practice. Now, there is part of your practice in orthopedics, which we call it office orthopedic treatment. Now, office orthopedic treatment is to treat non-surgical cases. And one of the most important presentation is growing pain. If you look at the American College of Radiologists guidelines, it tells you clearly a patient who comes to you with pain around the joint or in an extremity, this pain is not justified by clinical pathology, like he had no tendinitis, obvious tendinitis, and the pain is not relieved by simple maneuvers or simple prescriptions of analgesia, then you need, after 4 weeks, to go for any cross-sectional images. Most likely you go for MRI. Again, this is trick number one. So go for further imaging. Trick number two, after this lecture, you need to go back and read how do you need to look at X-rays in more what we call it eagle eyes. بمعنى ما هي نظرة سطحية. It's a very deep look toward the X-rays. In another lectures, I can show you a very normal X-ray. Like if you look at it, not you, I mean any other orthopedic surgeon, he looks at the X-rays. I think anybody who worked with you, I intentionally show you these cases because there is no abnormality in X-rays from the first look. But when I show you the MRI showed you a distal tibia osteosarcoma, massive distal tibia osteosarcoma. But how did we know this? I show you the X-ray again and look for fine cortical details. First, second, loss of corticomedullary differentiation, because if you have a permeative lesion within the cortex, then that cortex will be rarefied, so difficult to determine whether this is cortex or medulla. We call it loss of corticomedullary differentiation. And the second and the most important thing, you look for any subtle periosteal reaction. These are the tips and guidelines. Now, in the distal radius case, why did you use an ulna for reconstruction, not iliac crest or fibula? Many reasons. أولا, if you look at the distal radius reconstruction, you will find plenty of literature that tells you what you need to do. Now, in reconstruction, like we always think about resection and then we think about reconstruction. If you go in further details of reconstruction, I can explain it to you. Now, in reconstruction, I have cases where I use the bone cement and arthrodesis nail only. I have cases where I use the distal radius 3D printed implants. We can use the proximal fibula because anatomically we know that the proximal fibula looks like the distal radius. Now the iliac crest, I don't know what you mean by iliac crest. It's a very long segment, about 20 centimeter resection. You cannot take a 20 centimeter resection from the iliac crest. But why didn't use the fibula? Because I know the fibula has so many complications. First, I need to reconstruct the lateral collateral ligament. Second, the issue of peroneal nerve injury can be there, especially in long reconstruction. Third, it's another kind of surgery, which I don't need it. And fourth, why do I have to have the ulna if I do an arthrodesis of that area? Especially, I am resecting the proximal and distal row. So I don't have joint. I have only metacarpals and I have a distal ulna. So I cross transfer the ulna myself as osteoperiosteial and muscular transfer and centralize it within the third metacarpal and fix proximally to the remaining distal radius. So to me, it gives me an excellent result.
Do you have any more
Any,
questions يا
any
شباب?
other questions يا شباب؟
I think we can end it here. يعطيك العافية دكتور عماد، شكرا جزيلا على هذا المحاضرة العلمية، ما قصرت، الله يكتب لك الأجر، وشكرا لوقتك وجهدك، وإن شاء الله لنا لقاء في محاضرات قادمة بمشيئة الله. يعطيك العافية.
الله يبارك فيك يا عبد الرحيم، أشكرك جدا على الدعوة و I'm always available if you guys need anything. يعني الشباب أكيد في جزء من الشباب معنا بالروتيشن. They have my number, they have everything if you all need. I think this lecture is recorded. If you need the lecture, I can always give it to you. I don't have any issues. The main aim أمانة هو إنه really نكون honest وحريصين جدا على to pick up these cases لأنه this is extremely important and very lethal if not treated appropriately. بارك الله فيكم جميعا، أسعد الله مساءكم، إن شاء الله نراكم على خير وبالتوفيق.